So I think it's kind of important to take a step back and try and understand this, and I think this takes us back to the mid-70s and the Diamond-Forrester classification. I think this is what we were taught back in medical school and as we've been doing our training, is how to risk stratify patients based on simple criteria that include risk factors, age, gender, and symptoms. And much of what we do in the clinic, in the office, is really question our patients in terms of their symptoms. And what the Diamond-Forrester classification really focuses on is the chest pain criterion. Essentially, we're talking about typical angina, atypical angina, and non-anginal symptoms based on these three criteria. So, and again, I mean, think about what you do in clinical practice. When we question our patients, we're asking them about typical symptoms of chest pain discomfort that are characteristic of quality and duration, whether they're provoked by exertion or emotional stress, and whether they're relieved by stress and sublingual nitroglycerin. I know that I do ask these questions, and this is what was used to define the classification. If there were three criteria, this was defined as typical angina, two criteria, atypical angina, 0, 1 is non-anginal chest pain. In their classification, they then subsequently took these patients to diagnostic angiography and really were able to show the prevalence of disease based on symptoms. So asymptomatic patients here, you can see, have a very low prevalence of disease. And symptomatic patients, as you go from non-anginal symptoms, atypical, and more typical angina, of course, the prevalence of disease goes up. But when you look at the female patient population, you can see that the prevalence of disease is actually lower than the male patient population. And the other thing that you will find is that female patients much more commonly present with atypical angina or non-anginal symptoms. This is just another way from the same manuscript looking at the predictability of the symptoms comparing men and women. You can see the frequency distribution here of coronary artery disease probability for men and women. And what this is simply showing very nicely graphically, I think, is that in the male patients, it is just much more specific. So if you've got typical angina, you have a much higher predictability of a high risk for coronary disease, whereas in the in the female patient population, it's much broader. So the typical angina really is much less predictable of obstructive coronary disease. So what we have now learned is that what is atypical symptoms in general has become fairly typical in the female patient population. So we should be considering these atypical symptoms as being more typical. Things such as sudden onset of weakness, shortness of breath, nausea, vomiting, indigestion, etc. All these types of vague symptoms really should be thought of as much more typical in this female patient population.